So I'm going to introduce Camille. So Camille Paynter's worked as a speech pathologist for almost 20 years in Melbourne and in London, and she primarily works with people who have neurological conditions such as stroke or progressive diseases. So in addition to her clinical work, she's studying for a PhD at the University of Melbourne, exploring decision-making capacity for people living with motor neuron disease and their carers.
Okay, so speech is produced by highly coordinated movements of the lips, mouth, tongue, vocal cords and respiratory system. Speech can be impacted by damage to those actual muscles or the parts of the brain responsible for controlling the nerves and muscles. Language. Language are the words and sentences, reading and writing. I like to think of it as a two-way system, in and out. So input, we've got comprehension and understanding, and output being our expression. Expression and comprehension are processed in different parts of the brain, but obviously need to be connected. They can be impacted differently though, which is important to know because some people might have a strength in one other than another. So for example, they might be better at comprehending than expressing. Lastly, communication. So that's broader than language alone, and it really encompasses the social aspects and how we interact with others, as well as non-verbal behaviour, such as body language, gesture, eye contact, tone of voice. And I like to think of communication as being, well, an example is you can communicate with someone where you don't share the same language as them. So how does it work? Well, our thinking skills initiate an idea which is converted into words, which is structured into a grammatically sound sentence, the right nouns and verbs, etc. And these words are converted into the right sounds in the correct order and then organised by a motor speech program that executes the muscle movements responsible for speech. Now, whilst all that's happening, you're monitoring the responses of the person that you're talking with to make sure that they're engaged and listening. So as you can see, and I think it's really important to know that communication is a really highly complex skill. Now, there's last 2 points I want to make about normal communication. Firstly, that communication is collaborative. So if it's not reciprocated, that can feel quite personal. It's also very natural to feel awkward when communication breaks down. And this is an unconscious rule that we've learnt, that silence is uncomfortable, so we avoid it. But actually silence can be really important for people with communication impairments. So we've heard quite a bit about the symptoms of the different variants, and I'm just going to give a brief description of the types of speech, language and communication changes that can occur in the different variants of FTD and the impact of that difficulty for carers. It's really important to acknowledge, of course, that presentations are different, that they can vary, everybody is different. And also important to say that there can be an overlap between the subtypes as the disease progresses. So in behavioural variant FTD, there's changes in behaviour such as emotional blunting, apathy, disinhibition and social withdrawal. And that can result in, for people, difficulty generating speech, which means they just don't talk as much. Conversely, being disinhibited can result in people talking for extended periods of time without allowing other people to speak. Family members describe this difficulty with their significant other as not responding in the same way emotionally. In semantic variant FTD, there's a breakdown in the semantic system which is responsible for our understanding of how things work in the world. So that loss of semantic knowledge leads to difficulty in knowing and understanding words, including the names of people and places and objects. Errors can sometimes have a semantic or a meaning base. So, for example, someone might say foot instead of shoe. And difficulties are evident with writing as well. Speech generally remains well articulated but can lack substance, so conversation might be a bit vague because of that word loss. People living with semantic variant might have significant difficulties understanding the speech of others because they've lost those meanings of words. Sometimes sentence level comprehension can be a bit better than single word comprehension though, because the whole context and more information within that sentence can sometimes be helpful. But as their understanding of the world reduces, people might become fixed on certain phrases or interests and routines. The impacts of these communication and language changes that carers report is a loss of intimacy and reduced reciprocal conversation where shared interests are lost. And this is really because people living with semantic variant FTD are having difficulty articulating their thoughts and ideas, having problem understanding, and can't follow conversations as well. I'm going to mention logopenic PPA, even though it's language onset Alzheimer's disease, but it does. People do present with language difficulties. And mostly the primary difficulty people are having with this variant is word finding difficulty, because retrieving the word is difficult. And this often results in slow speech rate, frequent pauses while trying to find the word. So expression remains grammatically correct, but the speech might contain sound errors or phonological errors. So desk becomes dex, or apple becomes papple. People with logopenic PPA can experience problems comprehending long and complex sentences, which presents as forgetfulness, but it's really because they haven't understood. Carers often describe their loved ones as talking less and experience reduced emotional intimacy. Apathy is common, which really presents as switching off from conversation, which carers report they find hurtful. People with non-fluent variant PPA present with non-fluent expression. So speech production might be slow and effortful, contain mispronunciations, and sometimes sound like stuttering. Sentence production might have grammatical errors as well. That speech production is associated with something called apraxia of speech, and it's a breakdown in that motor programming of speech. So someone might know the word that they want to say, but putting those sounds in the right order is disrupted. Comprehension of complex sentences is impaired, but single word comprehension is often spared. And writing might be relatively spared as well, and that's often used as a compensatory strategy. Apathy might be present later in the disease, which can result in social intimacy and shared conversation. As this variant progresses, it might declare itself to be a Parkinsonism condition. So, for example, corticobasal degeneration. And in these cases, people might experience increased difficulty with their motor systems and their movements, which leads to problems with their voice as well as their speech, and might involve problems with swallowing as well. So this is the perfect segue into talking about swallowing. And I just want to say that the medical term for swallowing problems is dysphagia. So swallowing is a really highly complex activity that requires planning and coordination of a number of different brain regions. Our eating and swallowing is monitored by our thinking skills, but enacted by a series of muscle movements and reflexes. When we swallow safely, food and drink passes past our airway, that's our voice box and larynx, or windpipe and trachea, and our lungs, and into the esophagus. But if swallowing safety is compromised because of muscle weakness or poor coordination or cognitive difficulties, food and drink can enter the airway, causing coughing and choking. Choking is a life-threatening event because it prevents breathing. However, if food and drink regularly enters the airway and ends up in the lungs, pneumonia can occur, and this is called aspiration pneumonia. Aspiration is the medical term for food and drink entering the airway. And aspiration pneumonia can be serious. It can lead to hospitalisation and even death, which is why swallowing difficulties shouldn't be taken lightly. Other significant impacts of swallowing difficulties can be poor oral health, malnutrition, and dehydration. So if you do observe these signs of dysphagia, coughing, choking, wet-sounding voice, particularly with eating and drinking, please speak to your speech pathologist or ask your GP for referral to a speech pathologist. We have identified specific problems with eating and drinking or swallowing, particular to the different variants presentations, and Wendy touched on some of this. So but I just will go through this briefly. So people with behavioural variant FTD, we see changes in eating behaviour because of the cognitive changes. So people might eat very quickly, they may not chew their food sufficiently, they might eat inappropriately. So for example, wanting a whole can of beetroot in one go. Dietary changes might be observed, particularly a preference for sweet food and drinks, or eating non-food items. In semantic variant FTD, those behavioural changes are also evident in eating and drinking, and people might only want to eat in a particular way, eat particular types of food, for example, specific colours or textures, and we call that food fatism. They might want to eat their meals at a particular time in a specific way with specific utensils, and we call that mealtime rigidity. And also due to that loss of semantic knowledge, they might consume non-food items. We don't often see swallowing problems with a non-fluent variant or logopenic until later on in the disease. But with the Parkinsonian syndrome, swallowing difficulties are more common because of the impaired motor system, muscle weakness, and cognitive difficulties. And so an oral and dysphagia might be exacerbated by those cognitive difficulties or lack of insight. So I've got here some safe swallow strategies. It's really important to get personalised advice, but here's just some general things you might find helpful. So if swallowing is particularly unsafe, speech pathologists might recommend modifying food and fluids, so really changing the consistency of what people are consuming. Some general advice though, reducing distractions, so not having the TV on during meal times. Offering finger food if utensils are becoming difficult for someone to manage. Simplifying the environment, so avoiding offering lots of different options at one time or different sets of crockery or cutlery, just one course at a time. Obviously at home that's a little bit easier, but certainly in the hospital setting where people get a whole tray, get a tray with their whole meal set up, that's something that I often have to take into consideration. Routine might help. Same time, same place, same cutlery. If someone's taking large mouthfuls and that's becoming problematic, often offering or using smaller spoons or cups might be a good way of circumnavigating that. There's a couple of foods that I like to call my problem consistencies, which tend to be dual consistency food and crumbly food. So dual consistency food where you have a solid and a liquid together, it's very difficult to manage from a coordination point of view. And loose or crumbly food, it's quite easy for people to breathe in. So being extra careful with those. Tablets, that's really a dual consistency where you're trying to manage a solid and a liquid together. Lots of people have trouble with their tablets. So trying to have a tablet with something where it can all go down in one go. So a teaspoon of yogurt or a little bit of banana, a teaspoon of jam, that sort of thing. I want just to provide some general communication strategies. So again, these need to be individual and they might change as disease progresses. There's some really good communication resources on the web, but also your speech pathologist will be able to provide that individual advice. But for everybody, not just people living with FTD, but for carers, ensuring your hearing and vision is corrected as much as able. The older we get, we know that those things can be problematic. Having good sleep. Being tired is not conducive to good communication. Allowing extra time for communication. It's complicated, it can take longer. Removing distractions, background noise. Can be very helpful. And I think a nice rule of thumb is to show more and talk less. But really importantly, and my lovely colleague that I work with, another speech pathologist, Marg Posibon, has taught me to know the person the dementia has. So really being, knowing what you know about that person, how they like information explained and presented, and respecting them for who they are or who they were. So to finish up, I wanted to talk briefly about speech pathology intervention and speech therapy, because I thought, and I hope I'm right, that you'd like to know about treatment. So early referral to speech pathology can be great assistance in tailoring communication strategies for people with communication impairments, and also for caregivers. The focus of treatment will vary, of course, according to individual needs. It won't provide a cure, but it will provide support. So what we know from the research that's been conducted with people with PPA around impairment-based therapy, so this is specifically word retrieval treatments, they can be effective. It usually involves reading and repeating a set of words. The research that's been done has been intensive therapy, daily with a clinician plus daily homework, and results have been shown to be effective during those studies. We just don't know at the moment how well it generalises to everyday conversation and other words, or how long those benefits last for. Another impairment-based therapy is script training, where people learn a variety of scripts with the aim that they can then use those sentences in conversation. Again, it's intensive and it has been seen to have lasting effect, but mostly for people with motor speech problems and improving grammar. This is really targeting people with non-fluent variant PPA. So another approach, and it's not just specific to PPA, but is compensatory-based therapy. There's limited research in this area, but it is actually commonly practiced, and mostly the intervention focuses on implementation of supportive strategies to compensate for difficulties, such as alternative communication aids, picture boards or communication devices, gesture and non-verbal communication. We know that group education is beneficial. People living with PPA and their families report the benefits of sharing strategies and receiving information in that way. There's also some nice evidence for communication partner training, where we train family members or close friends so they understand how to better communicate with people living with dementia or communication impairments more effectively. What we also know about speech therapy is, there's benefits and barriers. So certainly the research shows us that quality of life can be improved through speech therapy. Some of the barriers to successful speech pathology intervention is when someone doesn't have any family or carers to be involved, or if the carer isn't motivated to help with that therapy. It's also challenging if the person with the communication difficulties doesn't have any insight into their difficulties, or they're not motivated to participate. Unfortunately, we know too that there's some barriers here in Australia and also overseas to accessing that intensive therapy. In the public system, it's primarily due to insufficient funding. Very few public services have the ability to provide that intensive therapy. And in the private system, it's that cost-intensive treatment the cost of that can be prohibitive. So thank you. I hope I kept time. That's all I wanted to cover. We might have some time for questions. And I'm just going to flick the slide to just for some other communication strategies while we chat.
Hi, Camille. Thank you so much for that. We do have one question from the audience here. If FTD can include swallowing difficulties, might it also include issues with the sphincter muscle of the esophagus causing reflux?
Oh, good question. Generally, reflux isn't about that sphincter muscle. That sphincter muscle is controlled by the sort of complex mechanisms in the brain, and so generally reflux is more to do with, is a separate condition. So sorry, Claire, could you just read the question again for me?
Yep, no worries, Camille. So Dorita just wondered whether, because there's swallowing difficulties in FTD, whether there might also be difficulties with the muscles of the throat causing reflux.
Okay, sorry. So there might be some reflux related to dysphagia, not necessarily due to that sphincter muscle. In my experience, people can have reflux without having any swallowing problems, and not everybody with swallowing problems will have reflux.